This video will go over the approach to hypoxemia as well as your differential diagnosis for hypoxemia. This is extremely relevant. You are guaranteed at some point to find a patient that has low O2 sats. So it's good to have an approach to this situation. Now, to be clear, we're talking about hypoxemia, which is low blood oxygen or low SpO2. This is slightly different than hypoxia, which is decreased oxygenation at the tissue level, or at least decreased ability to utilize oxygen at the tissue level for some reason, either because it's not there or something else is going on. And your evidence of that would be signs of poor end organ perfusion, like elevated lactate, mental status changes, or dysfunction of whatever organ that is hypoxic. Anyways, when you look up the differential for hypoxemia, you almost always see these 5 things, which are low FiO2, hypoventilation, VQ mismatch, diffusion impairment, and shunting, or an intracardiac shunt specifically. Low FiO2 is almost never the issue because room air always has at least 21% oxygen in it, which should be good enough. But it is technically possible to deliver low FiO2 with the anesthesia machine. If you have your circle circuit and your patient is hooked up to it over here, running super low flows, so we're just adding little bits of oxygen to this circuit at a time. All the other gas is being recirculated around and our CO2 is being scrubbed out by our CO2 absorber. You could technically be using the oxygen in this circuit faster than you're adding the oxygen back. So in this case, you could be delivering low FiO2, although you should get some kind of alarm warning you that this is the case in this scenario. And of course, if there is some issue with the O2 delivery mechanisms of the anesthesia machine, you could also deliver a hypoxic mixture. Otherwise, this is very unlikely. Hypoventilation means that the minute ventilation for the patient is not adequate to provide them with enough oxygen. So anything that decreases your resp rate or your tidal volumes could potentially cause hypoxemia. So sedation, particularly with opioids, paralysis, would be a mechanical impairment to taking deep enough breaths. You could have obesity, hypoventilation syndrome, COPD or asthma, and bronchospasm, or a hypermetabolic state where you are taking what should be decent tidal volumes or resp rate, but your high metabolic rate demands that you have more oxygen. Both low FiO2 and hypoventilation issues respond very well to supplemental O2. We can double or quadruple even the amount of oxygen that someone gets with each breath by giving nasal prongs or a face mask. So if the issue is that they're just not getting quite enough oxygen, then we can fix that very easily. VQ mismatch is what we talked about in the past 2 videos, but we'll sort of review this again. You can have either a shunt, so this would be really poor alveolar ventilation, or you could have dead space, which is adequate ventilation, but poor flow. This is low ventilation, and this is low perfusion. Remember that shunt is the type of VQ mismatch that really causes issues with saturation, because you're putting your venous blood, which did not participate in gas exchange, back into your arterial system. So atelectasis, these are all the same things that we talked about before. Aspiration, foreign body, or a mucus plug, pulmonary edema, and consider all these things that can cause atelectasis, like obesity, increased closing capacity, laparoscopic surgery, causing the basilar atelectasis position, going supine, pneumothorax.
And remember that in general, dead space shouldn't cause hypoxemia except when your reduction in alveolar ventilation is so significant that you're actually hypoventilating. But this can happen when you have a large amount of dead space, like with a cardiac arrest or a massive PE. Then you're basically just talking about your second differential there of hypoventilation. The difference is these guys will have normal tidal volumes, so they may appear on first glance to not be hypoventilating, but when you take into account the dead space and therefore the reduced alveolar ventilation, they most certainly are actually hypoventilating.
Diffusion impairment is where the oxygen has a harder time diffusing from the alveoli to the capillaries, usually because of some interstitial issue, so interstitial lung disease or pulmonary edema, which will add a bunch of space between the alveoli and the capillaries. And for pulmonary edema, there are a few causes, but cardiogenic. You have negative pressure pulmonary edema or ARDS. Lastly, shunt always gets put into this list. So this would be a right to left intracardiac shunt. So this could happen with an ASD or a VSD under certain conditions. You can actually kind of condense this list because you have shunt listed twice here, once for intracardiac shunt and once under VQ mismatch for your intrapulmonary shunt. And for hypoventilation, you have it listed here, but technically significant increases in dead space will cause alveolar hypoventilation. So you could just call this hypoventilation, and then your issues would be low FiO2, alveolar hypoventilation, shunting, and diffusion. But I guess that gets a bit confusing, so don't go there. Just list these 5 things if anyone wants to know your differential for hypoxemia, because these are pretty standard across the board. Just remember that you'll have to list intracardiac shunts as a separate entity from your VQ mismatching. Let me just clean this up so it doesn't look like shunt is including the PE and cardiac output. That is for dead space. Anyways, that's your differential. On this side, we'll talk about the actual approach.